Welcome all of you to another video from Infotainment Unlimited. Today's topic is very important as it is related to critical care and cardiac monitoring. Most of you are working in critical care areas like emergency room, intensive care unit, etc., where cardiac monitoring is mandatory. Identify cardiac signs and symptoms early is very important for a nurse in critical care areas, as an action on time will save the lives. For this, it is essential to know the ECG and arrhythmias. You should be aware about the different arrhythmias and its management protocols. Here today, we are discussing about different cardiac conditions like tachycardia, bradycardia, and cardiac arrest, as in the ACLS mega code, which is very important for you for daily practice as well as for exams and interviews. Let us go to the first arrhythmia. See the picture. There is a flat line kind of arrhythmia you can see in the figure. Please check it out and tell what is this arrhythmia. This is asystole. It is coming in the non-shockable area of cardiac arrest algorithm. So for these non-shockable rhythms, for asystole, you have to follow the flat line protocol. That is the first thing you have to do. You have to check the connections, because when the connections are not proper, there is a possibility of getting flat line. So monitor connections you have to see. Increase the amplitude. This is also one of the important thing that I will discuss even later in next arrhythmias. Then if it is still straight line, this can be considered as an asystole, and the management for asystole as per the ACLS protocol is CPR chest compressions. Each 2 minutes you have to reassess the pulse, carotid pulse. Then injection adrenaline 1 mg every 3 to 5 minutes. Next arrhythmia, you can see here. Can you identify this arrhythmia? There is no definite P wave QRS complex, and this is also similar to straight line. Please find out and tell your answer, which is this arrhythmia. This is fine VF. As I have already mentioned you the flat line protocol for asystole or straight line. So you have to increase the amplitude after checking the connections. So when you are increasing the amplitude, you can see the fine fibrillatory waves you can see in the figure. So this is a fine ventricular fibrillation. This is coming under the shockable part of cardiac arrest algorithm. That is the significance why you have to identify or distinguish between flat line or asystole and fine VF, because asystole is a non-shockable rhythm and fine VF is a shockable rhythm. So here the immediate action is defibrillate 200 joule if it is a biphasic, and 360 joules if it is a monophasic defibrillator. Then similar to the other non-shockable algorithm, adrenaline 1 mg every 3 to 5 minutes can be given for shockable rhythm as well as in cardiac arrest. Then addition to that, anti-arrhythmic drugs also should be considered like amiodarone and lidocaine. Let us go to the next arrhythmia. Please see this ECG and find out your diagnosis of this ECG. This is Coyer's VF. This is coming under the cardiac arrest algorithm shockable rhythms. So shockable rhythm, the immediate action is to defibrillate 200 joules or 360 joules according to the type of defibrillator. Adrenaline 1 mg every 3 to 5 minutes to be given during the CPR, and anti-arrhythmic drugs like amiodarone or lidocaine should be considered for this arrhythmia. Let us go to the next. Please see this figure and try to find your diagnosis on this ECG. This is polymorphic ventricular tachycardia or polymorphic VT. If you find this kind of arrhythmia, you have to check the pulse. That is the first action. Usually it will come as pulseless, but sometimes for VT there will be pulse as well. So check the pulse, and if it is pulseless, then it is going to the cardiac arrest algorithm shockable, because ventricular tachycardia and ventricular fibrillations are the shockable rhythms in cardiac arrest algorithm. So it will go to the shockable rhythm. So same management as in other VF, defibrillation 200 joules or 360 joules according to a type of defibrillator. Adrenaline 1 mg every 3 to 5 minutes should be given, and antiarrhythmic here similar to the VF, amiodarone and lidocaine. And in Torsades de Pointes, magnesium sulfate also can be considered, because sometimes the polymorphic ventricular tachycardia will show a specific pattern, that is Torsades de Pointes. So that case you have to give magnesium sulfate. Now let us see this ECG and find out your diagnosis. This arrhythmia is Torsades de Pointes. You can see the spindle or spring shaped pattern in this ECG. This is a type of polymorphic ventricular tachycardia. Check the pulse. Usually it will be pulseless, and you will follow the cardiac arrest algorithm shockable. Defibrillate 200 joule or 360 joule according to the defibrillator. Then adrenaline 1 mg every 3 to 5 minutes, and antiarrhythmics and magnesium sulfate is the specific medicine for Torsades de Pointes. This is the next arrhythmia. You can just see the ECG and find out what is your diagnosis. This is monomorphic ventricular tachycardia. You can see it is a regular rhythm, but it is wide QRS complexes. You can see that's why it is ventricular rhythm, ventricular tachycardia. The management you can see here, if it is pulseless, so the first thing you have to see is the pulse, central pulse. If the pulse is present, it is a different management, and if it is pulseless, follow the cardiac arrest shockable algorithm. Same like 200 joule shock, then CPR, adrenaline every 3 to 5 minutes, antiarrhythmic, so on. So this pattern you have to follow if it is without pulse. But this kind of rhythms usually present with pulse. So if the pulse is there, again there is a question if patient is stable or unstable. This is the second question. If unstable, if the patient is unstable, then you will go for synchronized cardioversion 100 joules. So monomorphic VT, the management for pulse, and it is a unstable patient, the management is synchronized cardioversion 100 joule. If it is pulseless, straight away defibrillation 200 joule. Then if it is a stable patient with pulse, then expert consultation and cardiac monitoring, then antiarrhythmic like adenosine, amiodarone infusion, etc. can be considered. Next arrhythmia. Please see this ECG and identify what arrhythmia is shown in this ECG. This is supraventricular tachycardia. Supraventricular tachycardia, you can see here, it is P wave and QRS complex is not distinguished. The rate is very high, but QRS complex is very narrow. So it is a sinus only. But the thing is, The rate is very high. You can see it is almost around 180. You can see the small boxes in between and find the rate. These all details I can share you how to see the rate of the pulse by using small boxes, count of small boxes in between RR interval. These all things I will give you in detail in next sessions if it is required, according to your active participation and your requirements. So here it is supraventricular tachycardia. You already diagnosed this because the P wave is not definitely found here, and it is rate is very high and narrow complex. So regular rhythm. So supraventricular tachycardia, if it is unstable, again it will go for synchronized cardioversion 50 to 100 joules. For stable patients, the first step is vagal maneuver. So sometimes the vagal stimulation will reduce the heart rate. It will come down to normal, near normal level. Then the specific medicine of choice here is adenosine 6 mg. Then repeat 12 mg. Expert consultation, beta blockers, calcium channel blockers like diltiazem, beta blockers like metoprolol can be considered in this arrhythmias. Next arrhythmia, you can see the figure. You see the figure and find out what kind of arrhythmia is this. This arrhythmia is atrial flutter. You can see the particular pattern. This is a regular rhythm and you can see the saw-toothed appearance of P waves. You can see in between the QRS complex saw-toothed appearance. This is the typical characteristics of atrial flutter. So same like the other tachycardia, if unstable or stable is the question. If unstable, synchronized cardioversion 50 to 100 joules. The common rule is if it is narrow complex regular, you will choose 50 to 100 joule. This is the rule. So these two are atrial flutter and supraventricular tachycardia. These two are narrow complex regular rhythm. So 50 to 100 joules you will select. Expert consultation and antiarrhythmic also will be considered here. Blood thinners, catheter ablation, etc. are also the management protocols. Next, you find this ECG and try to identify this rhythm. This arrhythmia is atrial fibrillation. For atrial fibrillation, if unstable, you have to go for synchronized cardioversion. Before that, you can just see the ECG here. In this ECG, you can see the RR complexes are not equal. Some are very big and some are small, so it is not having a uniform pattern, so it is a irregular rhythm, but QRS is narrow, so it is a sinus rhythm. So this is atrial fibrillation. No P waves, fibrillatory waves you can see in between the QRS complexes. So here the management, if unstable, synchronized cardioversion 120 to 200 joule. If stable, expert consultation, antiarrhythmic like beta blocker, calcium channel blockers. Then blood thinners, catheter ablation also can be considered. Here, please identify this rhythm. This rhythm is tachycardia, but just sinus tachycardia. So for sinus tachycardia, the treatment is to treat the underlying cause, because the sinus tachycardia will always subside when you treat the underlying cause like fever, pain, etc. Then monitor and observe for other kind of arrhythmias. Try to identify this rhythm. Here, the clue is you can see the big boxes or small boxes in between the QRS complex. The first rhythm which was given previously was only few boxes in between the RR, so it was tachycardia. Here you can see so many boxes in between the RR and donor, so it is indicating the sinus bradycardia. Here sinus bradycardia, if stable, monitor and observe the symptoms. But if unstable, atropine 0.5 mg bolus every 3 to 5 minutes, maximum 3 mg should be given. Then transcutaneous pacing, dopamine infusion 2 to 20 micrograms per kg per minute, epinephrine infusion 2 to 10 micrograms per minute. Expert consultation for transvenous pacing is the final strategy for the management. So, for bradycardia, this algorithm is same for all kind of bradycardia rhythms, including blocks. So, stable means monitor and observe. Unstable means starting with atropine, then every 3 to 5 minutes, we can give maximum dose is 3 mg. Transcutaneous pacing can be considered. Dopamine infusion can be considered 2 to 20 microgram, and epinephrine infusion 2 to 10 microgram can be considered. Then final thing is expert consultation and transvenous pacing or TVP. Next arrhythmia, please identify this arrhythmia. This is first degree AV block. You can see the prolonged PR interval. The management is same as bradycardia management. Similar to the bradycardia management, like stable means monitor and observe. Unstable means atropine, transcutaneous pacing, dopamine infusion, epinephrine infusion, expert consultation and transvenous pacing. Identify this arrhythmia. Here, this is second degree type 1 AV block. You can see the specific pattern here. The PR interval is keep on increasing and then one QRS complex is missing. Again, the PR interval is just increasing, then more again, then one QRS complex is missing. You can see the pattern here. If you need more explanation on these blocks and other ECGs, I will give you another session as per your requirement. If more people require this session, I will give you. So now just to please see the management. So the second degree type 1 AV block also, the management is same as bradycardia management, which is, I told you, stable patient monitor and observe, then unstable patient atropine, starting from atropine, 3 to 5 minutes, maximum 3 mg, transcutaneous pacing, dopamine infusion, epinephrine infusion, expert consultation, and transvenous pacing. Now let us see this arrhythmia. This arrhythmia is second degree type 2 AV block. Here you can see the PR interval is fixed, but multiple missed beats can be observed in this ECG. That's why this is second degree type 2 AV block. Here also the management is same as bradycardia management, like atropine, then transcutaneous pacing, dopamine, epinephrine, expert consultation, etc. But the difference is atropine is not likely to be effective in second degree type 2 and complete heart blocks. So atropine don't consider much here. Now let us identify this arrhythmia. This is complete heart block or third degree heart block. Here you can see the pattern. There is no relation between P wave and QRS complex. P wave is coming by its own and QRS is coming by its own way. There is no pattern or relation. So this is complete heart block. This is also same as bradycardia management, but atropine, same like second degree type 2, atropine not likely to be effective here also. So transcutaneous pacing, then dopamine infusion, noradrenaline infusion, epinephrine infusion, not noradrenaline, epinephrine infusion, dopamine infusion, and transvenous pacing with expert consultation. All those are the management. Let us see this arrhythmia and identify the type of arrhythmia. This is left bundle branch and right bundle branch block pattern. Bundle branch blocks. So here in left bundle branch block, you will see the pattern saying William. You can see here W and M. Then right bundle branch block, you can see the pattern of Morrow. M and W. First V1 it is M and V6 it is W. But here in LBB, V1 it is W and V6 it is M. So remember the term William and Morrow for left bundle branch block and right bundle branch block respectively. The management for bundle branch block is pacing. Try to identify this idea in this ECG. This is myocardial infarction. We can see the ST elevation pattern in this ECG in V4, V5, V2, V3, V6 leads. So myocardial infarction, the management is monotherapy, morphine, oxygen, nitroglycerin and aspirin. In STEMI, fibrinolytic therapy, angiogram, PTCA, etc. is done. Door to needle time is 30 minutes, door to balloon time is 90 minutes. In STEMI, low risk ACS, adjunctive therapy, example, heparin, expert consultation, etc. will be done. Thank you all for watching this video. Please add your valuable feedback for more videos. If you need any additional video on ECG or any specific topic related to this, please let me know by the comments and I will add more videos. Thank you so much.